Okay, hi, back. That class was a long class, so we're going to talk briefly here about chapter 4. It shouldn't take that long to get through. Let me see. It's this one. Sharing that screen. Okay, and the slideshow from the beginning. Okay, so some screen sharing, so I'll move this out of the way because it drives me crazy. All right, so chapter 4, treatment settings and therapeutic programs. Many different treatment settings are out there. We kind of spoke to them in chapter 3 a little bit. This is just go into a little bit more. Just remember, inpatient is stabilizations for acute. Client-centered, usually multidisciplinary, and psych nursing, it takes a village to take care of our patients. We also have case management in institutions that help to sort out those long-term issues, but usually the stay is only about maybe 3 days. Inpatient, longer patients who need to stay, they're coming out now and they're saying that it's not a recreation of the asylums, but it is a recreation of long-term homes, not group homes, but supervised housing. Excuse me. It's the end of the day. Supervised housing for people with severe persistent mental illness. So partial hospitalization, if you're in clinical with me right now, the reason we can't have that one room for our pre-conference that the Tuesday group can use, the IOP room, is because they do have their day program in there as a partial hospitalization. It goes from about 7:30, 8 o'clock all the way till 11:30. So, but that is kind of what they're talking about. Outpatients or people who are patients come in, they get reinforcement in classes and things like that to achieve some of these broader goals. Residential settings, people who need supervised housing vary. Group homes, I'm sure you've heard of. Supervised apartments, Coleman has some of those. Board and care homes, assisted living, adult foster care, and crisis housing, which is what Coleman is crisis housing. Transitional housing, halfway houses, things like that. The progress, or they're expected to progress to independent living. I've worked at some halfway houses, drugs and alcohol, the detox there is really intense. Some programs out there go longer. The ones I worked at was 28 days, but some will go even 30, 42. It just depends. And then there is crisis housing or respite housing, which is really short-term shelter until they can find some place. I did have a group of students that went to Coleman Services, which is just down on Main Street. And she was there, this patient was there the entire 16 weeks, which was highly unusual. But they were trying to get her skilled to go into a nursing home. She had some clear signs of dementia, but every time they were assessing her with the mini mental status exam, she was capable of passing it. So she was at that area where she was too dangerous to live home alone, or not dangerous enough to, I'm trying to say she was dangerous, but she was getting by. And that's not what they wanted to see. So, board and care homes are an example of a partial hospitalization. That is not true. Partial hospitalization, they live at home, they come back in for meetings and things. Um, Board and care homes are residential. Psychiatric rehab, we spoke to that a little bit. There's a couple of different programs that are out there, focuses on recovery, but it's not really recovery, it's more adaptation to living in the world that we live in. Symptom control, medication management, reintegration into the community, and empowerment and increased independence. All of those things are really fragile in your mentally ill patients. So these psychiatric rehabilitation services sometimes take a longer time to help the people get through and become more and more independent. The clubhouse model is one example. It has guaranteed rights of members. They have a place to come home to. They can work. They have meaningful relationships, which is with the physician, not with other people that are in there. And they can always come back if they need to. So focus on health, not illness, and adaptation to outside community, living on their own and being independent. There are a couple of different programs. The ACT program, Assertive Community Treatment, it's very effective. Coleman has an ACT section of their building, which is downstairs, is direct supervision of service rather than a referral. Intense services with no time constraints. Up there, they have a coaching model. So they have former addicts who serve as coaches to current addicts who are trying to recover. And then we have information and communication technology. This could be, we saw up on 70, we saw Dr. T being pulled around by Morgan, his PA. So we have telepsychiatry, telepsychology, telemental health, and e-mental health, phone apps, web-based diaries, group participation. During COVID, I know I make you go to groups now, but during COVID, due to the fact that we could not get out and go to these groups, people did a lot of virtual groups, online groups. I don't think you get the same feel, but that's kind of what we had to do during COVID. People were going to groups from Australia and all over the world. And that was cool. We learned a lot. But again, like I said, I don't think they're as effective as live interaction. So please make sure you attend your group. Other communication kind of things, video conferencing. I know I've had video conferencing with my family physician and gotten prescription refills, and that's all e-prescribing. Just go straight to your pharmacy or whatever mail out company you use. Those are all part of the psychiatric rehab model. So is the following treatment statement true or false? In the Clubhouse model, the relationship between clients is the most important. That's false. It's the doctor. Yeah. Clients with complex needs, homeless people with mental illness. Homeless people with mental illness, there's probably a third of them who are homeless, who are mentally ill. And usually they're the ones who spend a little more time in jail, a little more time being homeless longer, just because their reality is not our reality. They spend a lot of time in shelters, and usually family doesn't have a lot of contact with them. And we all know about, well, maybe you don't know about being homeless, but you do know that you need a computer to get a job these days. So, and these people don't have that. Now, the homeless center downtown that we were probably going to go to is called Changing Seasons. They have like a block of computers up there that the people can go to look for jobs and to input and have a home base that they can make application to different places. So it's kind of a nice bridge that we have going on Lima right now, but I don't know that it's all over. The PATH program, it's transitioning from homelessness. This is another project that Coleman has. So they have homeless people and they work to get them into supervised housing or into group homes, depending on what they can handle, or the psychiatric rehab. Center for Mental Health Services is out there. It's very prevalent in this area. They do have a board of directors, which is pretty much how we have all of these community centers now starting to pop up, like Brightview. Coleman is one. There's one in Arrowhead. I can't remember what that one's called though. Oh, it's called Arrowhead, but it's north of us. They have a new one in the Amish community in Holmes County. That is a Center for Mental Health Services. It's a new one. We have Foundations, which isn't necessarily a homestead, but it is like a community assistance with mental illness. So that's kind of nice. And then Westwood over in Van Wert. Also, the other special population are prisoners. We have a whole set of incarcerated individuals. They're 5 times likely than the general population to be mentally ill. So factors for placement in criminal justice, we've already spoke about deinstitutionalization, lack of adequate community support, economicization of treatment of mental illness, so money, and then attitudes. Police these days, I think, are much better regarding mental illness than they used to be. So, but in the bigger cities, that may not always be the case. Barriers to community reintegration. If you're in a mental health wing of a prison, usually you come out, they give you $50 and a bus token or whatever. And so you're pretty poor. And if you have no place to go, you're also homeless. Because adaptation to mental illness, you have maybe a week's worth of meds, you use your meds and they're done. You might turn to substances, illicit substances to deal with the mental illness that you have, which makes you more likely to become a victim of violent crime, if not being violent yourself. And of course, people who get really just kind of disheartened or disbelieving in hope anymore, they do tend to self-harm. Military, PTSD and major depression is greater in the military than in civilian counterparts. And I have a lot of friends who were in Iraq, and they came home with some serious issues. There's increased rates of suicide, homicide, injury, sleep disorders, substance abuse, smoking, homelessness, all of that with PTSD, which we'll speak to a little more in depth when we get there. Actually, the military or the veterans are a little more resistant to seeking treatment. And I mean, that just makes sense. They're the hero. They're the one who doesn't need saved. They're the ones that do the saving. But if should they decide they want to, then they're also the ones that are going to be stigmatized, and they're also the ones that don't have the services available. The VA and mental health, it's just like everything else with the VA. It meets the bare minimum, but it does happen. In addition, we have sexual traumas that happen that can contribute to PTSD. It doesn't just have to be war. We do have services. Again, the VA is an option. Some people choose to go there because it is economical. But again, like I said, they tend to be the minimum of what people can receive. Of course, mental health I've told you, it takes a village. There we are right in the middle of psychiatric nurses. We get the pharmacist, the vocational rehab specialist, the rec therapist, which is what Rayanne is at St. Rita's, which you'll find out when we start going to groups. She is the recreational therapist. They play games. That's kind of fun. Psychiatric social worker, that's Megan, who's up there. They have an OT sometimes. And then the psychiatrist and the psychologist. And the difference between those is the psychiatrist can prescribe, the psychologist cannot. Interdisciplinary team, they should have a core set of skills, including tolerance, patience, warmth, acceptance, empathy. They should be knowledgeable, be able to communicate, be assertive, be able to work on a team, and be able to mitigate risk. So this is kind of the epitome of why we need to have all hands on deck in mental illness, because some people don't know what they don't know. I don't know all of the things that are out there in the community that is available to the mentally ill, but my liaison or our liaison to Coleman does. He's a social worker and he does a great job. Likewise, the risk management, risk assessment may be something that the vocational PT does. They can say, hey, you know what? They're capable of taking care of these skills or these jobs, but that's too much stress and it'll trigger them. And that's probably not a wise choice for them to move forward with. So again, takes a village. So which discipline is most likely included as a part of the interdisciplinary team? Well, we don't really need a dietitian. I guess they're good if you're talking about medications. Don't really need a physician's assistant. We got the psychiatrist, the psychologist. Physical therapist, that's usually if there's something physical wrong. So I'm going to say, I want to say pharmacist because we definitely need one of those to adjust the medications. Ha, there we go. Are not typically involved, but they can be. Public health and home care, primary prevention, stress management, education. We all have stress and we need to learn how to deal with it effectively. Secondary prevention, early identification of mental health problems. That's going to be your PHQ 9. I'll show that in class when we get to depression. It's depression screening they do in physicians' offices, if you've ever seen one. And then tertiary prevention, monitoring and coordinating psychiatric rehab services. That would be more like Coleman. There are different kinds of practice issues that are in the public that you can join in as a nurse, including substance abuse, domestic violence, child abuse, grief, depression. There's just tons of them. Human trafficking, that's the one we're going to have a guest speaker for. Sexual assault, nurse practitioner, we're going to have her come in. But there's a lot of subspecialties, and they all usually require some sort of certification. They do have what's called a SANE certification for the sexual nurse examiner. They have it for adults, and they also have for pediatrics. So again, it's a subspecialty that is part of public health that you can investigate if you think you might like that kind of nursing. And then, of course, you have to be aware of yourself. I actually wanted to be trained as a SANE nurse, and I was going through the training, and I was encouraged to do the pediatric portion of it because, you know, even though I'm not really good with kids, kids really like me. I don't know. But to physically assess a child who's been sexually assaulted was not something I think I could do. An adult, yes. But a child, no, I don't think I could do that. So I stepped out of that and decided that I really probably would be better served educating about it and letting others who had a better feel of their control, personal control, emotional control, who could be advocates for these types of patients take over. So, but you really have to worry about can you handle what you're going into? It's something to think about, regardless if it's mental health or ER or ICU or surgery or whatever you think your chosen field is. It's just it's a tough decision. So don't make it lightly. I think that is it for chapter 4. Yay, that wasn't long. It took all of 15 minutes maybe. I'm gonna stop my share. Yay, we're back. Just doing the quiz today, looking at the quiz today. Make sure you do the Kahoot. I should have that up, I want to say by tomorrow. Yeah, because you guys' test, if it's not tomorrow, it will definitely be Tuesday. Because your first quiz over chapter 3 and 4 is not until the 8th. So 8th and yeah, 8th or 9th. And you should have the Kahoot, do the Kahoot. It's going to help you a lot over these 2 chapters. I think it's about everything I wanted to get in today. So anyway, thanks for listening. Sorry I didn't have this up before. Hope it helps you out, and I'll talk to you later. Bye.